Hey everyone, welcome to the channel. For those of you that don't know me, I'm Kevin, a new grad nurse who graduated with a 4.0 GPA and spent a lot of time peer tutoring and TAing in nursing school. Now that I graduated and passed the NCLEX, I wanted to break down the high yield topics and what was most commonly tested about them. My goal for these videos isn't to make you know everything. It's for people who want to see what nursing school is like, and for those already in it, it is to focus on the core concepts that I saw tested the most as a student, tutor, and TA. Keep in mind that I am just a new grad and things in healthcare can always change. Also, if I say something that disagrees with what your professors have told you, my advice is to go with what they say because they're the ones grading your exams, not me. Now that we got disclaimers out of the way, today we're diving into one of the most tested and sometimes confusing topics, electrolyte imbalances. I'll be using slides from one of my lectures I made when I was a TA, so it has some depth to it, but we'll only be focusing on the big things to know. Let's go. So, let's start things off with sodium. Its normal range is 135 to 145, and the big thing to remember is sodium is attached to neuro. That's your cue for your symptoms. Whether it is too low or too high, it will affect the brain. Now, low sodium, aka hyponatremia, causes water to rush into the cells, which can lead to cell swelling, especially in the brain. The symptoms you're going to see are headaches, irritability, difficulty concentrating, and if it gets worse, seizures and coma. So how do we treat it? Well, it depends on the cause, but some things are fluid restriction, giving sodium via an IV, or stopping diuretics. The reasoning behind what you give depends on the concentration of fluid and the body's fluid status, such as hypovolemia, hyponatremia, but that is a little more in depth than I would like to cover. The big takeaway is to always monitor the sodium levels and watch for seizures. Never, ever change sodium levels quickly, okay? You can cause irreversible changes. So, when you're replenishing someone's sodium levels, you have to do it slowly. High sodium, hypernatremia, is the opposite. Water is pulled from the cells, causing cellular dehydration. Classic symptoms are thirst, confusion, lethargy, and possibly seizures leading to comas. Now, remember, never change the sodium levels quickly. Just remember, sodium messes with your brain, okay? Next up is potassium. The normal range is 3.5 to 5.0. This one is all about the heart. So think about potassium being equal to the heart. Low potassium or hypokalemia causes muscle weakness, cramping, and can slow down the gut. The NCLEX loves to test EKG changes, and your professors may also want to throw in some questions involving an EKG. Hypokalemia changes the EKG in several ways, but the biggest one that you can take away is that there will be a U wave present. That is the big one to know. If you see U wave in the stem of the question, you can probably safely assume it is hypokalemia. Now, if your patient is hypokalemic, you want to continuously monitor their EKG. They should be on a heart monitor, okay? And IV potassium should never be pushed faster than 10 milliequivalents per hour with the pump, okay? You have to use a pump, and it should never go beyond this rate. The ICU can have special circumstances, but that is a little too advanced right now. Also, some things to know is that potassium chloride can be irritating to the vein, so you can dilute it before you give it. Now, on the flip side, hyperkalemia, it can also cause EKG changes, and it can cause deadly arrhythmias. Now, the key word to note in the test question are tall T waves. If you see the stem tall tented T waves, that's a pretty sure sign that the patient is hyperkalemic, okay? So you also want to monitor their heart rhythm, and you want to give them continuous EKG monitoring. Some of the things that you can do are stopping their potassium intake and also trying to get the potassium out of them through diuretics, dialysis, and a popular medication called Electrolyte, which will make them have a lot of diarrhea. You can also force the potassium back into the intracellular fluid, but that's a little bit more advanced, so we won't really cover that too much. This is mainly for a med-surg course. It's not going to go into critical care where we're talking about insulin, albuterol, and other methods of forcing potassium back in. Also remember that if things are bad, you can give calcium gluconate or calcium chloride to help stabilize the heart. Now, the third one we're going to cover today is calcium. It has two ranges here, 9.0 to 10.5 or 4.5 to 5.6. The value that we got tested on the most is 9.0 to 10.5, okay? And there are two hormones that regulate calcium blood levels, calcitonin and parathyroid hormone. They're both released by the parathyroid gland in response to the calcium levels in the blood. Now, which one is for which? I want you to think PTH, parathyroid hormone, as pump that horn. When there are low levels of calcium in the blood, you want to pump that horn. So you pump that calcium into the blood, okay? On the other hand, calcitonin is when there's too much calcium. You want to lower it down. So calcitonin, tone the calcium down, or calcibonin to improve the reabsorption of calcium back into the bone, This will decrease the blood calcium levels. Now, hypocalcemia is one of the most testable electrolyte imbalances because it has a very notable symptom: positive Chvostek's and Trousseau sign. A positive Chvostek sign is facial twitching when you tap on the facial nerve in front of the ear, on the face, in front of the ear, and it'll cause some twitching. Trousseau sign is when you have the blood pressure cuff around the patient's arm, and when you inflate it, around 3 to 5 minutes, their hand will start to twitch and their arm will start to twitch. There will be some spasms. Okay? You don't need to know the detail of how long you keep it on there, but just basically know if there's twitching of the face or a twitching of the arm with the blood pressure cuff on, it's usually indicating there's a positive Chvostek's or Trousseau sign. Also, keep in mind paresthesia around the mouth. Circumoral paresthesia, or numbness, is going to be used later on to determine if it's hypocalcemia or a different type of electrolyte imbalance. It is what I use to break the tie, basically. Now, hypercalcemia, I use this little rhyme: bones, moans, stones, and groans. There's bone pain, there's going to be moaning, there's going to be depressed reflexes, and there's going to be kidney stones and groans from the abdominal pain and constipation, okay? So low calcium, they're twitchy. Hypercalcemia, they're slowed down and sluggish, okay? And the treatments are very self-explanatory. If they're low on calcium, you want to try to up their calcium levels, and if they have too much, you want to stop them from taking any more. Give calcitonin to bring the calcium back into the bone, or biphosphonates, which is phosphorus, and that's the next one we're going to get into. Phosphorus has a range from 3.4 to 4.5. Now, this one is not tested as much as the other 4 electrolytes we're going to cover, and the biggest thing you need to know is that it has an inverse relationship with calcium. So what does that mean? It means that if calcium goes up, phosphorus goes down, and vice versa. Some common causes are kidney damage and hypoparathyroidism. So if there's low parathyroid hormone, there's going to be a lot of phosphorus in the blood because of the inverse relationship that we went over on the calcium slide. It's usually asymptomatic, and you'll usually see the hypocalcemia signs first, so I want you guys to think of the Chvostek's and Trousseau's sign. Now, low phosphorus is usually caused by malnutrition, malabsorption, diarrhea, and phosphorus binding antacids. The symptoms are also very vague, but the big one I want you guys to remember is rickets and osteomalacia. It causes bone problems, okay? But then again, this electrolyte was not tested very often at all. Okay, so the last one is magnesium. It has a range of 1.8 to 2.2. That's really narrow. That's a 0.4 difference here. And what I want you guys to associate with magnesium is that it's a CNS depressant, a central nervous system depressant, which means that it controls the blood pressure, the respiratory rate, the heart rate. And the way I remember that is bath salts often have magnesium in them. And you want to relax, you pour yourself a nice bath. But if you have too much bath salts, aka too much magnesium, you're going to be way too sluggish, way too relaxed, right? So some common symptoms are the flushing warm skin. There's going to be decrease in deep tendon reflexes. There's the hypotension, the low blood pressure, bradycardia, the slow heart rate, and if it gets severe enough, respiratory and cardiac arrest. Now, how do we treat it? Well, if it's running, you stop the infusion, stop putting magnesium in them. You want to get it out by giving them fluids and diuretics, and the antidote, IV calcium gluconate. And on the flip side, hypomagnesemia, it's very similar in presentation to hypocalcemia. Remember Chvostek's and Trousseau's sign? It's come back. And what did I say earlier that I use to break the tie if I see Chvostek's and Trousseau's sign on the question? The tiebreaker is the circumoral numbness. That's one way that you can tell if it's going to be magnesium or a calcium problem. Now, a big safety tip is if you're giving IV magnesium, always give it through an infusion pump and always have IV calcium gluconate ready, because you can easily cause a cardiac or respiratory arrest since the therapeutic range is so narrow. You don't have much of a margin to play with. All right. Our last slide here is that there's going to be some relationships between electrolyte levels. There's some trends going on. And sodium and potassium have an inverse trend. So if sodium goes up, potassium goes down, and vice versa. Calcium and phosphorus, we went over this already, but it's also an inverse relationship. And same with magnesium and phosphorus. The only big direct relationship that I've seen is calcium and vitamin D, okay? Because they help each other absorb. There are a couple others, but they're a bit more complicated than what an entry level or a new grad nurse needs to know. But hopefully these things help you for your test questions and guide you in your clinical judgment. And that's it. I hope this helped make electrolyte imbalances feel less scary. If you want the slides, let me know in the comments. You guys can also let me know what topic I should cover next, and don't forget to like and subscribe if you found this helpful. See you guys next time.